Good afternoon, dear students. Today we have a lecture for third-year students for MM groups who have a second semester of third year or sixth semester. And topic of our today's lecture, it is the signs and symptoms of urinary system diseases. And today I'm going to discuss with you several syndromes. It is urinary syndrome, nephrotic syndrome, nephritic syndrome, urinary tract obstruction syndrome, and hypertensive syndrome. And before we start, I'm going to remind you that it is one of the last lectures. It will be one more in this semester. And in the December you will finish a cycle of Propaedeutics of internal medicine, and you will have a final test with the final mark. That's why please be attentive and prepare to the final test from general about 2 semesters of Propaedeutics of internal medicine. Hope it will be all okay in every our student. Okay, in our today's lecture, we will talk about importance or value of human kidney, about urinary system diseases, syndromes like urinary syndrome, nephrotic, nephritic syndrome, urinary tract obstruction, and hypertensive syndrome. It will be some reminder how the kidneys work and primary function and purpose. And some words about history taking, patient's examination, and spectrum of urinary system diseases and urinary system diseases symptoms. The importance of human kidney. A human kidney, it is a body filter, so you know it from the physiology. It cleans nearly 180 liters of liquid per day, retaining a good stuff and expelling bad. More fortuitously, humans are born with 2 kidneys. If one of them becomes damaged, the other one can pick up the slack. If both kidneys fail, however, body will be filled with harmful toxins. Without medical intervention, such patients will die within several weeks. And first syndrome for today, it is urinary syndrome. It is the simplest one, and mostly it is laboratory. Let's define it. The urinary syndrome, it is quantitative and qualitative changes in urine in laboratory urine test. Symptoms of it is changes in volume and composition of urine output, changes in the rhythm of urinary excretion, changes in the volume and composition of the blood. Another syndrome for today, it is nephrotic syndrome. About this syndrome I want to talk with you a little bit more. It is clinically and laboratory syndrome characterized by massive proteinuria, which lead to hypoproteinemia or hypoalbuminemia, hyperlipidemia, and pitting edema in result from increased permeability of glomerular basement membrane to plasma protein. Criteria of nephrotic syndrome. It is hematuria, like red blood cells in urine, gross hematuria, hypertension more than 140 per 90, azotemia, renal insufficiency with increased level of serum urine and creatine, and hypocomplementemia, a decreased level of serum complement C3. Types of nephrotic syndrome. In most cases, more than 90%, it is idiopathic, or it is a type when we can't know the exact cause of this syndrome. And in other 10%, it can be secondary or congenital. Secondary most often due to anaphylactoid purpura, systemic lupus erythematosus, hepatitis B virus infection, etc., more rare causes. And it can be congenital in some rare cases. Pathophysiologically, the nephrotic syndrome goes, first of all, due to glomerular damage. It leads to increased permeability to proteins and lead to proteinuria. For nephrotic syndrome, it is typical massive proteinuria, the intensive one, with a level of proteinuria more than 3.5 grams per day of proteins in urine. And such an intensive secretion of proteins to urine lead to hypoproteinemia, to insufficiency of them in the blood. And it have two another results. First one, it is decreased plasma oncotic pressure with edema and compensatory synthesis of proteins by liver with hyperlipidemia. Decrease of proteinuria, it can be mild, it can be moderate, and it can be severe. For nephrotic syndrome, which I told you, more than 3.5, it is severe proteinuria. If it is less than 0.5, it mild proteinuria from 0.5 till 2 grams. It is moderate, and more than 2, it is severe. Moreover, proteinuria can be selective and non-selective. What it means? Selective, it where the proteins of low molecular weight, such as albumin, are excreted more readily than protein of high molecular weight, like for example globulin. When it is non-selective proteinuria, it is both as low molecular weight and as high molecular weight are lost in urine. Symptoms. Edema. It can be varying degrees as local. Most often it is edema of face, facial edema, edema around eyes, we name it periorbital swelling, and edema of lower extremities. It is less specific than face edema for kidney problems, but it's possible too. And it can be in severe cases generalized edema, or we name it with term anasarca, if you remember, with edema of penis and scrotum. Other clinical symptoms include fatigue, lethargy, loss of appetite, nausea and vomiting, abdominal pain, diarrhea, body weight increase, urine output decrease, and pleural effusion with respiratory distress. Tests that we usually use to diagnostics of nephrotic syndrome and differential diagnosis. Laboratory tests that we use usually include blood tests. The most typical changes for nephrotic syndrome will be serum protein more than 5.5, albumin less than 2.5, and cholesterol more than 220 milligrams per deciliter. In urine test, the typical changes, it is proteinuria, oliguria during stage of edema formation. It can be microscopic hematuria, nearly in 20% of patients, and large number of hyaline casts. It demands the differential diagnostics of generalized edema. Main criteria of nephrotic syndrome altogether we can include in one classification, and all words here contains letter O. It is massive proteinuria, it is hypoproteinemia, it is peeling out albumin first of all. It is edema with oncotic pressure in the blood goes down. It is hypercholesterolemia with hyperlipidemia and hyperlipiduria, and hypercoagulable state, which is very often for nephrotic syndrome too, with thrombotic and thromboembolic complications. And I have for you a USMLE test about nephrotic syndrome. As usual, it's for your individual work, for your self-controlling. A 7-year-old male suffers from generalized edema. Urine protein excretion is 5.2 grams or 24 hours, and serum analysis reveals hyperlipidemia. The patient responds to treatment with prednisone, and 8 weeks later his urine does not contain measurable protein. if a kidney biopsy has been performed while a patient's condition was pathologic, which of the following would you expect to find upon glomerular electron microscopy? First, it is effacement of podocyte food processes. Second, it is subepithelial spike and dome deposits. Third, it is subepithelial humps. Fourth, thin glomerular basement membrane. And fifth, it is subendothelial thickening. A 57-year-old female visited her primary care physician with an intensive pitting edema plus it is quite intensive of her legs. She takes no medications and does not use alcohol, tobacco, or illicit drugs. 4.5 grams of protein are collected during 24-hour urine excretion and kidney biopsy is obtained. Examination with light microscopy shows diffuse thickening of the glomerular basement membrane. Electron microscopy shows subepithelial spike and dome deposits. Which of the following is the most likely diagnosis? Here, please be attentive because this USMLE test there contains a lot of morphological and pathophysiological microscopic information, but really very often you will meet in your test, in CROC test, in USMLE test, such question. That's why it is quite difficult, but if you have problems with it, you should stop on this moment and return to pathophysiological and morphology of glomerulonephritis and of nephrotic syndrome. And after it, return to this question. I think they will be much more easy for you. Options for this question. First, it is minimal change disease. Second, it is post-infectious glomerulonephritis. Third, focal segmental glomerulosclerosis. Fourth one, rapidly progressive glomerulonephritis. And fifth, it is membranous glomerulopathy. Third question. A 6-year-old girl presents to your clinic 2 weeks after receiving a routine immunization in preparation for trip overseas. Periorbital edema is present on exam and 24-hour urine collection shows excretion of 4.3 grams of protein per day. Which pathological change would likely be seen on microscopy? First one, it is linear immunoglobulin G deposition on light microscopy. Second, immunoglobulin A immune complexes in the mesangium on electron microscopy. Third, it is tram-track appearance on light microscopy. Fourth, subepithelial deposits with spike and dome appearance on electron microscopy. And fifth, it is podocyte effacement on electron microscopy. Next syndrome for today, it is nephritic syndrome. It is different from the previous one just in one letter, but clinically the difference is significant. Let's give definition. What is nephritic syndrome? It is clinical and laboratory syndrome associated with disorders affecting the kidneys, more specifically glomerular structures, and characterized by having a thin glomerular basement membrane and small pores in the podocytes of the glomerulus, large enough to permit proteins like proteinur and red blood cells, hematuria, to pass into the urine. Criteria of nephritic syndrome. It is if they are in nephrotic, it was proteinuria. For nephritic, on the first place it is hematuria. Usually it is with red blood cell cast present in urine. On second place it is proteinur. It usually present in nephritic syndrome too, but it usually not such an intensive. The excretion of proteins is less than 3.5 grams per day. Moreover, very typical for nephritic syndrome, it is hypertension, uremia due to retention of waste products, variable renal insufficiency with azotemia and oliguria, with low urine output less than 400 milliliters per day. Types of nephritic syndrome include post-streptococcal glomerulonephritis, crescentic glomerulonephritis, rapidly progressive glomerulonephritis. And criteria, they're usually the same with the syndrome nephritic. All of them contains letter I and are responsible to mnemonic pharaon, where P it is proteinuria, H hematuria, A azotemia with elevated blood nitrogen levels, R it is red blood cell casts. One more time, A it is antistreptolizine O titers if post-streptococcal infection, or it is oliguria, output less than 0.5 milliliters per kilogram per hour, and hypertension. And USMLE test about nephritic syndrome. Multiple patients present to your office with hematuria following the outbreak of group A streptococcus. Biopsy reveals that all of the patients have the same disease characterized by large hypercellular glomeruli with neutrophil infiltration. Which patients has the best prognosis? First, 65-year-old nulliparous woman. Second, 50-year-old man with a history of strep infection. Third, it is 8-year-old boy who undergoes no treatment. Fourth, 38-year-old man with sickle cell trait. And fifth, 18-year-old man treated with corticosteroids. Question 5. A 10-year-old boy presents to your office with a color-colored urine and periorbital edema. His mother is extremely concerned, especially given that her son has been entirely healthy except for sore throat a few weeks ago. Which of the following you be least likely to observe on a kidney biopsy of this patient? First, it is lumpy, bumpy appearance in immunofluorescence. Second, it is subepithelial electron-dense deposits on electron microscopy. Third, it is polyclonal immunoglobulin G and C3 deposition on immunofluorescence. Fourth, it is linear immunoglobulin G deposition along the basement membrane on immunofluorescence. Fifth, it is large hypercellular glomeruli on light microscopy. Next test. A 6-year-old boy presents to your office with hematuria. 2 weeks ago, the patient has symptoms of sore throat and fever. Although physical exam is unremarkable, laboratory results show a decreased serum complement level and elevated anti-DNase B titer. Which of the following would you most expect to see on renal biopsy? First option, it is large hypercellular glomeruli on light microscopy. Second, polyclonal immunoglobulin A deposition on immunofluorescence. Third, immune complex deposits with a spike and dome appearance on electron microscopy. Fourth, it is viral lupin and hyaline thrombi on light microscopy. Fifth, antibodies to GBM resulting in linear immunofluorescence pattern. Test 7. A 21-year-old male presents to your office with hematuria 3 days after the onset of productive cough and fever. Following renal biopsy, immunofluorescence shows granular immunoglobulin A deposits in the glomerular mesangium. Which of the following do you suspect in this patient? First, it is lipoid nephrosis. Second, Berger's disease. Third, post-streptococcal glomerulonephritis. Fourth, systemic lupus erythematosus. And fifth, it is HIV infection. One more time, please. It looks like difficult, but if you understand the microscopy in nephrotic and nephritic syndrome, it's all possible for answer for yourself. Next syndrome, it is urinary tract obstruction syndrome. Urinary tract obstruction can occur at any point of urinary tract, from the kidneys to the urethral meatus. It can develop secondary to calculi, tumors, strictures, anatomical abnormalities, or functional abnormalities. Obstructive uropathy can result in pain, urinary tract infection, loss in renal function, or possibly sepsis or death. Symptoms are typified by the symptoms of urethral stricture or urethral or renal stone. The principal complaints are pain in the flank radiating along the course of the ureter, gross total hematuria, gastrointestinal symptoms, chills, fever, burning on urination, and cloudy urine with the onset of infection, which is the common consequence of obstruction of vesicoureteral reflux. Nausea, vomiting, loss of weight and strange and the pallor due to uremia secondary to bilateral hydronephrosis. Anemia, leukocytosis, microscopic hematuria can be present in this syndrome. Ureter in the early stages, intravesical pressure is normal. Later added stage effect at the lower end of the ureter induce further hydroureteronephrosis. Finally, the ureteral wall becomes attenuated. Typified by the symptoms of ureteral stricture, benign prostatic hyperplasia, neurogenic bladder, and tumor of the bladder involving the vesical neck. Symptoms include hesitancy in starting urination, lessened force and size of the stream, and the terminal dribbling, hematuria which may be partial, cloudy urine due to complicating infection, acute urinary retention, anemia, leukocytosis, microscopic hematuria. Mid-tract obstruction. Stages include compensation when the bladder musculature becomes hypertrophic. For compensation, the thickness may double or triple. Hypertrophic muscle can be seen endoscopically and it leads to hyperimposed with a secondary infection. And next stage, it is stage of decompensation, with a large obstructing gland can be palpated rectally and observed cystoscopically may appear as a mild obstruction cystoscopically. Lower tract obstruction. The principal symptoms are hesitancy in the starting urination, lessened force and size of the stream, and terminal dribbling. Hematuria, which may be partial initially with a stricture of total with prostatic obstruction of vesical tumor, cloudy urine due to complicating infection, acute urinary retention. Moreover, it usually associated with anemia, leukocytosis, and microscopic hematuria. Obstruction in case of lower tract obstruction lead to hydrostatic pressure, increased hydrostatic pressure more proximally of this place. It leads to dilation of urethra. The wall of urethra becomes thin. It forms the diverticulum. Infected urine and urinary extravasation lead to periureteral abscess. Typified by the symptoms of ureteral stricture, benign prostatic hyperplasia, neurogenic bladder, and the tumor of the bladder involving the vesical neck. And one more test for you. A 45-year-old man presents with a 3-day history of right-sided flank pain due to a lodged ureteral stone. What changes would be expected to be seen at the level of glomerular filtration? First option, it is increased in glomerular capillary oncotic pressure. Second, increase in the Bowman-Spence capillary oncotic pressure. Third one, increase in Bowman-Spence hydrostatic pressure. Fourth, it is increase in filtration fraction. And fifth, it is non-change in filtration fraction. Next question. A 72-year-old male presents to his primary care physician with urinary hesitancy and urinary dribbling that began 6 weeks ago and has gradually worsened. A rectal exam reveals a markedly enlarged prostate. CT scan demonstrates dilated ureters and renal pelvises. Which of the following likely accounts for the CT scan results? First option, it is ureteral obstruction. Second, autosomal dominant polycystic kidney disease. Third, prerenal azotemia. Fourth, elevated serum PCR or prostate-specific antigen. And fifth one, it is multiple endocrine neoplasia type 1. Next syndrome. For you, it is hypertensive syndrome. Elevated more than 140 by 90 millimeters hydrargium blood pressure, caused most often by renal or renovascular secondary hypertension, caused by narrowing in the arteries that deliver blood to the kidney. Renal artery stenosis. When the kidneys receive low blood flow, they respond by releasing hormones that stimulate the body to retain sodium water. It is renin, angiotensin, aldosterone system. Blood vessels fill with additional fluid and blood pressure increases. The narrowing in the one or both renal arteries is most often caused by atherosclerosis or hardening of the arteries. Symptoms include headache, confusion, blurred or double vision, bloody or pink-colored urine, nosebleeds, bruise over affected renal artery. Hypertension can cause chronic kidney disease. And short reminder for you about the primary urinary system function. For what we need kidneys. Hope you remember from physiology, but let's remind. Functions of urinary system: to maintain homeostasis, to regulate fluids and electrolytes, to eliminate waste products, to maintain blood pressure, involved with the red blood cell production, involved with the bone metabolism. Purpose of investigation of patient with excretory system problems. First of all, it is, as usual, general evaluation of health. It is diagnosis of disease or disorders of the kidneys of urinary tract. It is diagnosis of other systemic diseases that affect kidney function. Monitoring of patients with diabetes, screening for the drug toxicity, like sulfanilamide or aminoglycosides. In history taking or patients interviewing, we pay attention to gathering of information, patient's narrative, biomedical perspective, psychological, psychopsychological perspective, and context. It is a topographic anatomy of man and woman urinary tract, just for reminding you, hope you remember. And skeletotopy, you see the normal position, anterior view and posterior view position of kidneys. And it is a typical position for palpation of kidneys. Patient lying supine and patient standing or sitting, and palpation of kidneys have to be beam anal. When one arm you put under the back, and with the second arm you start to palpate and find the kidney into the abdomen. You will more practice and more detailed discussion of palpation of kidney on practical classes. And you see topical localization of kidneys and allocation of kidney pain. General inspection of patient. In general state of health, the most typical it is fatigue, lethargy, diminished alertness, skin pallor, yellow-gray excoriation, changes in turgor, bruises, texture like rough or dry skin. Sorry, one moment. I need a little warm. Changes from the face and extremities. It is generalized and peripheral edema, bladder distension. It can be masses, enlarged kidney. In abdomen, we can find abdominal contour for midline mass in the lower abdomen or unilateral mass due to kidneys, enlarged kidneys. Changes with weight. Weight gain secondary to edema and weight loss can be, and muscle wasting in renal failure. Percussion, palpation, and auscultation. Investigation of kidneys. In percussion, you can detect areas of tenderness by costovertebral test, and palpation. With palpation, we can find contour size size and tenderness. Presence of tenderness and pain indicates a kidney infection of polycystic kidney disease. Bladder. In percussion of area over the bladder 5 cm above the symphysis pubis to detect a difference in sound percussion towards the base of the bladder. Sorry, one moment. In ureteral meatus. It is inspection for swelling, discharge, and inflammation. During auscultation, we can auscultate the abdominal aorta and renal arteries for bruits, which indicate impaired blood flow on the kidneys. Laboratory examination. In blood test, we check the most important things. It is serum creatinine. It have to be from 0.5 till 1.2. Blood urea nitrogen from 10 till 20, and blood urea nitrogen to creatine ratio. It have to be 12 to 1 or till 20 to 1. In urine test, we check general urea analysis, urine for culture and sensitivity. Composite urine collections, usually we use 1 day or 24-hour collections. The very important test, it is creatinine clearance test. It is used to estimate GFR or glomerular filtration rate. We check urine for urine electrolytes and osmolarity, as for plasma as urine. Okay, checking GFR. I told you that it is one of the most important tests. We can measure it by several ways, and it will indicate you a level of filtration function of kidneys. GFR, it is a test of how much kidneys are filtering. Normal, it is about 100 milliliters per minute. This means that kidneys are removing all the creatinine found in 100 milliliters of blood every minute. It can be measured and estimated. Measure GFR. It is an invasive method with injecting a tiny amount of radioactive substance and measuring how quickly it disappears from the blood or appears in the urine is used to calculate GFR. And estimated GFR or calculated GFR. We can do it using blood test, age, sex, and sometimes other information to estimate the GFR from the MDRD or modified of diet renal disease equation. This isn't as good as measuring, but is much simpler and requires just one blood test and general information for the patient. That's why it's much more cheap and much less invasive and damage for patient. Creatinine clearance. It is blood creatinine measurements by collecting urine for 24 hours and measuring how much creatinine is in the urine at the same time as finding out how much it is in the blood. If any urine produced during 24 hours is not collected, the result will not be accurate. And formulas, how to check estimated GFR and creatinine clearance. For estimated GFR, we use MDRD, modified of diet in renal disease, and you see the first formula of it. And for creatinine clearance, we use most often Cockcroft-Gault equation. You see second formula for it. Both of them are quite specific and give us information about kidneys filtration function. And according to level of eGFR, we can classify kidney damage or renal insufficiency by the stages. It stages from 1 till 5 and several substages. Stage 1, it is when the normal GFR more than 90, but it is present damage of kidneys, but still with normal filtration. Stage 2, it is a mild decrease in GFR from 60 to 89. Stage 3, it is moderate decrease of GFR. It is subdivided on two substages, 3A and 3B. 3A, it is GFR from 45 till 59, and 3B from 30 till 44. Stage 4, it is severe decrease of GFR and severe renal failure with a level of eGFR from 15 till 29. And stage 5, it is kidney failure when GFR less than 50. And it have one more substages. It is 5D. It when GFR less than 10. It is indication for emergent hemodialysis. And according laboratory examination, first that we can check macroscopically, it is color of urine, and this picture shows you how different it can be in different kidney damages. Urgent cases, it's possible to random urine, and it have to be for urine culture, it have to be clean catch midstream urine. And it is important thing that urine have to be examined within 1 hour after collection. Urine specimen examination, it can be physical, like appearance of urine, volume and specific gravity. It is chemical analysis, microscopic examination, and a checking of urine for culture and sensitivity. Physical appearance, color can be normal, pale or dark yellow. We name it urochrome. Abnormal types. Some drugs can cause color changes, like for example red urine can be in hematuria, hemoglobinuria, myoglobinuria, pseudohematuria. Yellow-brown or green-brown urine typical for bilirubin increasement in obstructive jaundice. You remember what is that. According to clarity, it can be normal, clear, or abnormal and cloudy. Cloudy, it most often due to crystal or non-pathologic salts, due to phosphate carbonate in alkaline urine, due to uric acid in acid urine, and various cellular elements like leukocytes, red blood cells, epithelial cells. Microscopic hematuria. Usually we see it in urinary tract source like urethra or bladder, prostate, ureter or kidney. But it can be in from non-urinary tract source like vagina, anus or rectum. We have one more term, it is pseudohematuria. Usually it caused by myoglobinuria, hemoglobinuria, phenolphthalein laxatives, phenothiazines, porphyria, rifampin, pyridium, bilirubinuria, phenytoin, pyridium, red deer diaper syndrome, and some food like beets, blackberries, rhubarb. Causes of asymptomatic gross hematuria like acute cystitis, bladder cancer, benign prostatic hyperplasia, nephrolithiasis, benign essential hematuria, prostatitis, renal cancer, pyelonephritis, prostate cancer, and urethral stricture. According to urine volume, it can be normal, normal adult overage, it is from 400 till 2 liters per 24 hours. Increased overage we name polyuria, it when the daily urine more than 2 liters, and it can be physiological, for example due to increased water intake, due to some drugs or IV solutions. And polyuria can be pathological due to chronic kidney disease, diabetes mellitus or diabetes insipidus most often. And it can be decreased overage. We name it oliguria and anuria. What the difference between them? Oliguria, when the daily urine is less than 400 milliliters, and anuria, it when the daily urine less than 100 milliliters. Urine volume due to prerenal causes, it can be hemorrhage, dehydration, congestive heart failure. Oliguria due to renal parenchymal disease can be in acute tubular necrosis in chronic renal failure. And it can be post-renal due to obstruction of the urinary tract, it may be stones or carcinoma. Specific gravity of urine. It is density of urine compares to density of urine or to the density of water. The normal average in adults is 0.001 till 0.040. And specific gravity can be increased, for example, in dehydration, in fever, vomiting, diarrhea, diabetes mellitus, other glycosuria, congestive heart failure, syndrome of inappropriate adrenal antidiuretic hormone secretion, or diabetes insipidus, or adrenal insufficiency. And it can be decreased specific gravity. When urine volume decrease, specific gravity increase. For example, in diabetes insipidus, when urine volume increased and specific gravity decreased. Urine pH. It can be normal from 5 till 9, depends on diet. It can be increased, we name it alkaline urine. Mostly it can be caused by drugs like sodium bicarbonate, classic renal tubular acidosis, alkalosis, metabolic or respiratory, and it can be decreased, or we name it acid urine, due to drugs like ammonium chloride, acidosis, metabolic or respiratory. Chemical examination of urine by containing of proteins, and normally it's less than 150 milligrams per 24 hour. Higher than 150 we named proteinuria. Proteinuria, you remember I showed you this classification: heavy more than 4, moderate from 1 till 4, and minimal less than 1 grams per 24 hours. And it can be microalbuminuria from 30 to till 300 milligrams per day. Glomerular diseases damage. It can be due to glomerular causes like glomerular diseases damage glomerular basement membrane, but tubular function is normal. It will be selective proteinuria, heavy proteinuria, and acute glomerulonephritis. But it can be not just glomerular, it can be tubular. With renal tubular disease damage, tubular function, yet glomerular is normal, moderate proteinuria, pyelonephritis, and overflow functional extra rare. Chemical examination include glucose. It usually normally negative, positive in diabetes mellitus, Cushing's syndrome, and renal tubular dysfunction. Ketones normally negative. Ketonuria can be in diabetic, non-diabetic, hyperemesis of pregnancy, and patients with vomiting or diarrhea. Alcohol blood normally negative. Bilirubin, urobilinogen normally negative, positive in jaundice. Nitrates usually negative, positive in presence of nitrates, positive in presence of bacteriuria. Leukocyte esterase can be in bacteria, fungal, parasitic, tumor, or nephritis. Microscopic urine for culture and sensitivity. Microscopically, we can see red blood cells, white blood cells, epithelial cells, bacteria, casts like cylindrical molds indicate damage to the glomerular basement membrane or tubule. And instrumental patients examination include ultrasonography or ultrasound. We here use BMOD scan or Doppler flow examination of renal vessels or duplex ultrasound scanning. Radiographic examination can be of kidneys, ureter, bladder, X-ray, intravenous urography, computer tomography, cystography, and cystoureterography. Other diagnostic tests include renal arteriography, angiography, renal biopsy, renography like kidney scan, and magnetic resonance imaging or MRI. It is a looking of sonography of kidneys with Doppler ultrasonography of patients with refractory hypertension with massive proteinuria. In such way, it looks renal arteriography when it is injected contrast to the artery system, and according to X-ray picture, you see picture completely of abdominal aorta and renal arteries. It is urography. It when the contrast injected through the catheter retrograde to the ureter, and it is visualization of all side of urinary system by the contrast. X-ray picture, and here you see example of radiolacent stone. You see on X-ray a huge stone of the cyst, and after operation you see this real photo of this stone. Computer tomography, it is used more rare than ultrasonography and X-ray, but in some not understandable cases when we're not sure with other visualization, we can use it. For example, here we see a cystic disease of the kidneys. You see that both kidneys, especially left kidney, it is a very with very changed structure with a lot of cysts. MRI imaging, it is for detailizing of some picture, not first choice visualization too, but in some cases is very useful. For example, here it is gonadal dysgenesis. Positron emission tomography, in some cases in very difficult diagnosing, can be used for visualization of kidneys too. And laparoscopic renal biopsy. On the photo you see the technique of this manipulation. How laparoscopically surgeons go with catheter and take a piece of biopsy from the kidney's tissue for analysis. Here you see plain radiography with abdominal computer X-ray. And here you see a left flank pay, and according to by the arrows it showed you a very widened structure of kidney, and it is a patient of left hydronephrosis. Spectrum of urinary system diseases. Let's include all diseases that we discussed today in all system in one classification. What diseases most often can be in urinary system? It is congenital abnormalities, it is interstitial nephritis, glomerulonephritis, cystic kidney disease, renal vascular disease, nephrotic syndrome, renal failure, infections of urinary tract, obstruction of urinary tract calculi and nephrocalcinosis, malignancy of urinary tract, including cancer of bladder and incontinence. And spectrum of urinary system diseases symptoms. What clinically in general in all these syndromes can be in the patient? Most often patient with excretory system disorders suffer from pain, proteinuria, azotemia leading to uremia, hematuria, urinary casts, hypertension, oliguria or anuria, edema, polyuria, renal or ureteric colic dysuria, renal failure, general symptoms of abnormal renal function. It is general symptoms of excretory system disorders. For today, that's all that I want to tell you. As usual, if you have questions, you can write it under the video in comments or on our Facebook page. I will be glad to your feedback. Sorry for the darkness in the camera, because you know we have problems with energy, and today one more time it's nearly whole country are sitting without the electricity. We make internet for working, that's why I can make my lecture. I'm on phone, but with problem we have problems with the light, that's why sorry for this darkness. And as usually, I ask all my students who listen in the lectures, write your name and group number in the comments under the video. For today, goodbye and see you in 2 weeks on the next lecture.